Operating room lighting systems are engineered for precision control. Surgical lamps must provide intense, shadowless illumination during procedures, then dim completely when operations conclude to allow proper room cleaning and equipment maintenance. After 15 years as biomedical technician at General Hospital, I had serviced hundreds of surgical lighting fixtures and understood their electrical systems thoroughly, which is why the surgical lamps in operating Theater 5 that refused to turn off presented such a puzzling maintenance challenge. The problem began following a midnight emergency surgery, a complicated abdominal procedure, on a trauma patient who had been injured in a construction accident. The operation lasted 6 hours, concluding at dawn with successful repair of internal injuries and stable patient condition. But when the surgical team attempted to power down the lighting system, the lamps remained illuminated. Dr. Patterson tried the standard wall switches, but the surgical lights continued glowing at full intensity. The anesthesiologist checked the main electrical panel, finding all circuits in their normal positions, but the illumination persisted. "Lights are stuck on," reported the charge nurse. "Maintenance needed in Theater 5. I arrived within 20 minutes, carrying standard electrical testing equipment and replacement components for common lighting system failures. But when I examined the surgical lamps, I discovered something that violated basic electrical principles. The lights were disconnected from their power source. During the troubleshooting process, the surgical team had unplugged the main electrical connections to force the lighting system to shut down, but the lamps continued to glow with steady, cold illumination that didn't correspond to any available power supply. I tested the electrical circuits with voltmeters, finding no current flow to the lighting fixtures. I checked the backup power systems, discovering they were inactive. I even shut down the main electrical panel for Theater 5, cutting all power to the operating room. The surgical lamps continued to shine, not with the warm, bright illumination they produced during normal operation, but with a pale, cold light that cast strange shadows throughout the operating room. "This is impossible," I told Dr. Patterson. "These lights have no power source, but they're obviously still functioning." I examined the lamp fixtures more closely, looking for hidden electrical connections or backup power systems that might explain the persistent illumination. But the lamps were standard surgical lighting equipment, with no exotic components or unusual modifications that would allow them to operate without electrical power. The light they produced was qualitatively different from normal surgical illumination. Instead of the shadowless, evenly distributed light that surgical lamps are designed to provide, these fixtures cast distinct shadows that seemed to move independently of the objects creating them. In the pale glow, I began to notice additional shadows that didn't correspond to any physical objects in the operating room. Shadow figures positioned around the surgical table, motionless but distinctly human in shape and posture. Some appeared to be standing, others seemed to be lying on stretchers, and several showed the distinctive outline of patients in surgical positions. "Do you see the shadow figures?" I asked Dr. Patterson. He studied the unusual lighting pattern carefully. "Those shadows don't match anything in this room." The shadow figures remained stationary, but they appeared to be observing the operating room activities. When staff members moved through the space, the shadows would turn their heads to follow the movement, displaying awareness and attention despite their lack of physical substance. Dr. Martinez, our chief of surgery, was called to assess the situation. He examined the lighting anomaly and the shadow figures with professional concern. "We can't use Theater 5 while the lighting system is malfunctioning," he decided. Patients shouldn't be exposed to unexplained electrical phenomena. But attempts to repair or replace the lighting fixtures proved impossible. When I tried to remove the lamp assemblies, they wouldn't detach from their mounting hardware. The screws holding them in place appeared to be fused to the mounting brackets, preventing disassembly through normal maintenance procedures. I attempted to disconnect the electrical connections, but the wiring had somehow become integrated with the lighting fixtures in ways that prevented separation. The surgical lamps had become permanent fixtures that couldn't be removed or repaired through conventional methods. Frustrated by the mechanical approaches, I decided to try more direct intervention. Using a hammer, I struck one of the smaller auxiliary lamps, hoping to shatter the bulb and eliminate at least part of the mysterious illumination. The lamp shattered as expected, with glass fragments falling to the floor and the tungsten filament becoming completely destroyed. but the light continued to shine. From the empty fixture, the broken lamp socket glowed, with the same pale illumination as the intact lamps, proving that the light source wasn't dependent on functional bulbs or electrical components. The light is coming from somewhere else, I reported to Dr. Martinez. Breaking the lamps doesn't affect the illumination. Over the following days, I systematically destroyed all the surgical lamps in Theater 5, shattering every bulb, disconnecting every wire, and removing every component that could possibly generate light. But the pale glow persisted, emanating from empty fixtures and broken hardware with consistent intensity. The shadow figures became more distinct as the mechanical light sources were eliminated. Without the interference of normal surgical illumination, the mysterious shadows appeared almost solid, showing details of clothing, posture, and facial features. I began to recognize some of the shadow figures as former patients who had undergone surgery in Theater 5. Mrs. Henderson, who had died during emergency surgery 2 years earlier. Mr. Thompson, who had succumbed to complications following routine gallbladder removal. Mrs. Garcia, whose cardiac procedure had been unsuccessful despite excellent surgical technique. The shadows represented patients who had died in Theater 5, continuing to occupy the space where they had received their final medical care. They're still here, I told Dr. Martinez. Former patients who didn't survive their surgeries. That's not possible. People don't leave shadows after death, but the evidence was compelling. Each shadow figure corresponded to patients whose surgical outcomes had been unsuccessful, displaying their characteristic postures and physical features in permanent silhouette. The persistent lighting seemed to be illuminating their continuing presence in the operating room where they had spent their final hours. Administration eventually sealed Theater 5, declaring it unusable due to unresolved electrical problems. But the pale glow continued to shine through the gaps around the locked doors, and staff members reported seeing shadow figures moving within the closed room. The sealed theater became a memorial to patients who had died during surgical procedures, their shadows preserved in the impossible light that wouldn't dim regardless of electrical disconnection or mechanical destruction. Some illumination, I've learned, doesn't depend on electrical power or functional bulbs, and some operating rooms continue to provide light for patients whose presence transcends the normal boundaries between life and death. The lights that wouldn't dim serve as lasting documentation of the patients who trusted us with their care during their final hours, ensuring that their shadows remain visible in the places where they received compassionate attention during life's most critical moments. Cardiac monitoring represents one of medicine's most fundamental diagnostic tools. Heart rhythm, rate, and electrical activity provide essential information about patient condition and treatment effectiveness. During my 7 years as cardiac monitoring technician at Regional Medical Center, I had observed thousands of electrocardiogram readings and understood the critical importance of accurate cardiac assessment. But Mr. Daniel Walsh presented a monitoring anomaly that challenged everything I knew about cardiac physiology and electronic measurement. He was admitted following chest pain and shortness of breath, symptoms that suggested possible heart attack or cardiac arrhythmia. Standard protocol required continuous cardiac monitoring to track his heart's electrical activity and alert medical staff to any dangerous rhythm changes. The monitoring electrodes were applied correctly. The equipment was functioning normally, and the baseline readings showed typical cardiac electrical patterns. But at 2:17 a.m., Mr. Walsh's cardiac monitor displayed a completely flat line. Systole. No electrical activity, no heartbeat, no cardiac function. The monitor alarm sounded immediately, indicating cardiac arrest requiring emergency resuscitation. I rushed to Mr. Walsh's room, expecting to find an unconscious patient requiring immediate life support. Instead, I found him sitting upright in bed, breathing steadily, speaking coherently with the night nurse. "How are you feeling, Mr. Walsh?" the nurse was asking. "Quite well, thank you," he replied with calm clarity. A bit tired, perhaps, but comfortable. His color was good, his breathing was unlabored, and he showed no signs of cardiovascular distress. But the cardiac monitor beside his bed showed a persistent flat line indicating complete absence of heart activity. "Sir, the monitor shows you're in cardiac arrest," I told him, checking the electrode connections for possible malfunction. Mr. Walsh looked at the monitor with mild interest. "That's curious. I feel perfectly fine. I verified that all monitoring leads were properly attached to his chest. The electrodes were correctly positioned, the cables were secure, and the monitor was receiving clear signals from the cardiac sensors. But the signals indicated no heart rhythm whatsoever. Dr. Peterson, the cardiologist on call, arrived within minutes to assess the contradiction between Mr. Walsh's apparent condition and his cardiac monitor readings. "Mr. Walsh, are you experiencing any chest pain or shortness of breath?" "No, doctor. I feel much better than when I arrived." Dr. Peterson checked Mr. Walsh's pulse manually, palpating the radial artery at his wrist. No pulse. He checked the carotid artery at the neck. No pulse. He listened to his chest with a stethoscope. No heart sounds. But Mr. Walsh continued breathing normally and speaking coherently despite showing no signs of cardiac activity. "This is medically impossible," Dr. Peterson whispered to me. "He can't be conscious and conversational without cardiac function." We attempted to resolve the monitoring problem by switching to different equipment. New electrodes, different monitor, alternative placement of sensors. But every cardiac monitoring system showed the same flat line indicating absence of heart activity. Mr. Walsh observed our troubleshooting efforts with patient cooperation. "Perhaps the problem isn't with your equipment," he suggested quietly. "What do you mean?" Dr. Peterson asked. "My heart isn't here anymore. It's elsewhere." The statement made no medical sense, but Mr. Walsh delivered it with the calm certainty of someone stating an obvious fact. "Where is your heart, Mr. Walsh?" He considered the question thoughtfully. "Somewhere it's needed more than here." Dr. Peterson ordered additional diagnostic tests to determine Mr. Walsh's actual cardiac status. Chest x-rays, echocardiograms, blood tests for cardiac enzymes. Comprehensive assessment to understand his physiological condition, but the test results were contradictory and confusing. The chest x-ray showed normal lung fields but no visible cardiac silhouette. The space where his heart should have appeared was clear, as if the organ were absent from his chest cavity. The echocardiogram produced no cardiac images. The ultrasound waves found no heart structure to reflect, resulting in empty recordings that suggested no cardiac tissue was present, but blood tests showed normal circulation patterns and oxygen levels consistent with adequate cardiac function. His blood is circulating normally, but we can't find his heart, Dr. Peterson reported to the medical team. Mr. Walsh remained alert and comfortable throughout the diagnostic process, showing no concern about his missing cardiac activity. "Have you ever experienced anything like this before?" I asked him. "Not exactly like this," he replied. "But I've always known my heart was temporary." "What do you mean by temporary?" "Some hearts are meant to keep their owners alive. Others are meant to help in different ways." Mr. Walsh's explanation suggested that his heart was serving a purpose other than maintaining his own circulation, but he couldn't provide additional details about where it had gone or how his body was functioning without it. Throughout the night, his condition remained stable despite the complete absence of detectable cardiac activity. His consciousness was clear, his breathing was steady, and his circulation appeared adequate despite having no identifiable heart function. At 6 a.m. during shift change, I provided report to the day monitoring technician about Mr. Walsh's unusual case. Patient shows persistent asystole on all monitoring equipment but remains conscious and stable. No explanation for cardiac absence or continued physiological function. But when the day shift nurse went to check on Mr. Walsh, his room was empty. The bed was neatly made with hospital corners. Personal belongings were gone, and there was no indication that anyone had occupied the room recently. "Where's the patient from room 314? The nurse asked. I checked the patient census. No, Mr. Daniel Walsh was listed as a current patient. No discharge orders had been written, no transfer arrangements had been made, and no record existed of his departure from the hospital. But his cardiac monitor continued to display the flat line that had characterized his entire stay, as if the equipment were still attempting to track the heart that had gone elsewhere. I searched the medical records for any documentation of Mr. Walsh's admission or treatment. The files contained evidence of his arrival, diagnostic tests, and monitoring data, but no indication of his current location or discharge status. His cardiac monitor readings remained in our computer system, hours of flatline recordings that documented the absence of the heart that had apparently been needed somewhere other than in his own chest. Some cardiac function, I've learned, serves purposes beyond maintaining individual circulation, and some hearts fulfill their essential work by going where they're needed most, even when that means leaving their original owners to continue existing through alternative physiological mechanisms. Mr. Walsh's missing pulse represents the redirection of cardiac service to locations where heartbeat is more critically required, ensuring that vital cardiac function reaches the patients who need it most. Hospital backup power systems are designed to prevent interruptions to critical patient care during electrical outages. Operating rooms maintain emergency lighting, essential equipment power, and communication systems through independent generators that activate automatically when primary power fails. During my 12 years as night supervisor at Memorial Hospital, I had managed several power outages without significant disruption to surgical procedures. But the blackout that occurred during Dr. Martinez's emergency appendectomy in Theater 3 created a containment situation that trapped the surgical team inside the operating room for 8 hours. The power failure began at 11:47 p.m. during a routine appendectomy on 16-year-old Sarah Chen. The procedure was progressing normally when the lights flickered, the ventilation system paused, and all electrical equipment switched to battery backup, Operation Standard Protocol during power outages required surgical teams to continue current procedures while maintenance staff activated the emergency generators. The backup systems typically restored full power within minutes. But Theater 3's emergency lighting failed to activate, leaving the surgical team working in complete darkness. "Emergency lighting is out," Dr. Martinez announced calmly. "Need flashlights immediately." I grabbed portable surgical lights from the equipment storage and rushed toward Theater 3. But when I reached the operating room doors, they wouldn't open, not locked, sealed. The electronic door mechanisms had engaged in a way that prevented opening from either side. The heavy steel doors that provided sterile isolation during surgery had become impermeable barriers that trapped the surgical team inside. "Dr. Martinez, can you hear me?" I called through the sealed doors. "We can hear you." His voice came faintly through the steel barriers. "Doors won't open from inside. We're continuing the procedure by flashlight." The emergency generators activated successfully, restoring power to the hospital within 10 minutes. But Theater 3's doors remained sealed, and the room's electrical systems didn't respond to the restored power supply. I contacted the biomedical engineering department for emergency door access. The technicians arrived with manual override tools, but the door mechanisms wouldn't respond to mechanical or electrical intervention. "These doors are designed to fail open during power outages," the lead technician reported. "They shouldn't be able to seal shut without specific electronic commands." But Theater 3 remained completely inaccessible from the outside. Through the sealed doors, we could hear the surgical team continuing their work. Dr. Martinez's voice giving instructions, the anesthesiologist monitoring vital signs, nurses providing instrument assistance, all conducted by flashlight and battery-powered equipment. "How's the patient?" I called through the doors. "Stable. Procedure is nearly complete, but we'll need door access for patient transport to recovery." The appendectomy should have required 30 more minutes under normal conditions. Working by flashlight would extend the procedure time, but the surgical team was experienced enough to complete the operation safely. But as the night progressed, we began hearing additional voices from inside Theater 3. Not the familiar voices of Dr. Martinez's surgical team, but other people speaking quietly in the background, multiple conversations, different voices, all muffled by the sealed doors but clearly audible. "Dr. Martinez, how many people are in there with you?" I asked. 4 team members, the usual surgical staff. But we were hearing at least 8 different voices engaged in various conversations within the operating room. I positioned additional staff outside Theater 3 to monitor the situation and provide assistance when the doors finally opened. But the voices we heard from inside the room didn't match the number of people who should have been present. Security guards, maintenance personnel, and additional medical staff gathered in the corridor outside the sealed operating room. Everyone could hear the multiple conversations occurring inside Theater 3. "Sounds like there's a crowd in there," observed Officer Johnson, our night security supervisor. At 3:30 a.m., the voices inside Theater 3 became more distinct. We could hear detailed medical discussions, surgical instruction, and patient care coordination. all involving more people than could physically fit in the operating room. But when we called through the doors, only Dr. Martinez's familiar team responded to our communication attempts. Dr. Martinez, we're hearing multiple conversations. Can you explain who else is in the room? Just the four of us, he replied. Surgery is complete. Patient is stable. We need door access now. But the sealed doors continued to resist all attempts at opening. At 7:45 a.m., nearly 8 hours after the power outage, the Theater 3 doors suddenly opened without warning or mechanical intervention. Dr. Martinez's surgical team emerged, wheeling Sarah Chen toward the recovery room. The appendectomy had been completed successfully, and the patient showed no complications from the extended procedure time. How did you manage an 8-hour appendectomy? I asked Dr. Martinez. He looked confused by the question. 8 hours? The procedure took 45 minutes. Standard timing. You've been sealed in Theater 3 all night. That's impossible. The surgery concluded around 12:30 a.m. We've been trying to leave for the past 15 minutes. According to Dr. Martinez's perception, the appendectomy had proceeded normally and concluded within standard time frame. But hospital records showed that Theater 3 had been inaccessible for 8 hours. I examined the operating room for any indication of the additional people whose voices we had heard throughout the night. Theater 3 was clean, organized, and showed no evidence of occupancy beyond the 4-person surgical team. But the voice recordings from our security monitoring system captured hours of conversations involving dozens of different speakers, engaged in various medical discussions within the sealed operating room. Who were all those people talking inside Theater 3? I asked the surgical team. Each team member looked puzzled by the question. They reported hearing only their own voices during the procedure and had no awareness of additional conversations or extended time. Duration. Security logs showed that the surgical wing had been empty throughout the night, except for the sealed Theater 3. No additional personnel had entered the area, no visitors had been present, and no unauthorized access had occurred. But the audio recordings documented extensive conversations involving medical professionals who hadn't been physically present in the hospital. Sarah Chen recovered completely from her appendectomy, with no complications from the procedure or the unusual circumstances surrounding her surgery. But the sealed Theater 3 incident raised questions about what happens inside operating rooms when they become isolated from normal hospital operations. Perhaps surgical procedures sometimes require more participants than the visible medical teams, drawing assistance from professionals who exist in spaces adjacent to our standard operating rooms. The voices we heard through the sealed doors may have represented additional surgical expertise that becomes available when operating rooms are temporarily separated from conventional hospital systems. Some surgical assistance, I've learned, comes from sources that exist outside normal staffing schedules and personnel rosters. And some of the most complex procedures are supported by professionals whose presence can be heard but not seen, ensuring that patient care continues even when operating rooms become isolated from the surrounding medical environment. Surgical masks serve as essential barriers between medical professionals and patients, preventing contamination while allowing clear communication during procedures. After 18 years of surgical practice at City General Hospital, I had worn thousands of masks and understood their simple but critical function in maintaining sterile operating conditions. But the mask I donned for Mrs. Eleanor Patterson's cardiac surgery changed my understanding of what surgical barriers can contain. The procedure was scheduled for 7 a.m., a routine valve replacement that should have proceeded without complications. I followed standard pre-surgical protocols: scrub, gown, glove, and mask, in the precise sequence that ensures sterile preparation for patient contact. The surgical mask felt normal when I first put it on. Standard disposable material, proper fit, appropriate filtration. But as I approached the surgical table, I began to hear something that shouldn't have been possible. Breathing. Not my own breathing, which I could feel and control, but additional respiratory sounds that seemed to originate from within the mask itself. Soft inhalation and exhalation that followed a rhythm different from my own. "Are you ready to begin?" asked Dr. Chen, the anesthesiologist. I nodded, but as I opened my mouth to respond verbally, I heard my voice speaking words I hadn't intended to say. "Patient shows excellent potential for complete recovery. Cardiac tissue is healthier than expected. The observation was medically accurate. Mrs. Patterson's heart condition was less severe than our preoperative assessment had suggested. But I hadn't consciously made that evaluation or intended to voice that comment. Dr. Chen looked puzzled. How can you assess her cardiac tissue before making the incision? I had spoken about surgical findings that hadn't yet been observed, using my voice to express knowledge I didn't possess about a procedure that hadn't begun. I'm not sure what I meant, I replied, but again my voice continued beyond my conscious control. The mitral valve requires minimal repair. Standard annuloplasty will restore normal function. This time I was certain I hadn't intended to speak. The words emerged from my mouth with my voice, but they expressed surgical judgments that I couldn't have made based on available information. Yet the observations proved accurate throughout the procedure. As I made the initial incision, the breathing sounds within my mask became more pronounced, not louder, but more distinctly separate from my own respiratory pattern. It was as if someone else were sharing the mask, breathing in rhythm with surgical activities. Excellent tissue quality, my voice announced without my conscious participation. Minimal calcification, good elasticity. Dr. Peterson, the perfusionist managing the heart-lung bypass machine, noted the accuracy of these observations. Your assessment matches exactly what I'm seeing in the cardiac output data. But I was making assessments before examining the relevant anatomy, speaking conclusions before conducting the analysis that would support them. The breathing in my mask intensified when I approached Mrs. Patterson's exposed heart. The respiratory sounds became almost conversational, as if someone were trying to communicate through shared airflow. Posterior leaflet shows minor thickening, my voice reported. Anterior leaflet is intact. Cord structures are strong. Again, accurate observations delivered in my voice, but originating from knowledge I hadn't yet acquired through surgical examination. The scrub nurse, Maria, began watching me with concern. Doctor, are you feeling all right? Your voice sounds different. Different how? Like someone else is talking through you. Your lips don't always match the words we're hearing. I became conscious of this disconnect. My mouth would move to speak, but the words that emerged seemed to come from a separate source that used my vocal cords to express surgical expertise I didn't recognize as my own. The valve repair is proceeding excellently, my voice announced, while I was still assessing the anatomical structures. Patient will have full recovery of cardiac function. Dr. Chen confirmed this prediction through his anesthetic monitoring. Her cardiovascular response is remarkably strong, better than we expected for her age and condition, but the predictions were being made before the surgical interventions that would determine their accuracy. The breathing in my mask began to sound more familiar as the procedure continued. Not just random respiratory sounds, but breathing patterns that reminded me of Dr. Morrison, my surgical mentor, who had died 3 years earlier. Dr. Morrison had been known for his exceptional ability to assess cardiac conditions quickly and accurately. His voice had the same measured cadence that I was hearing in my own speech during this procedure. Annuloplasty ring size 28 will provide optimal support, my voice declared, using Dr. Morrison's characteristic precision in equipment selection. The valve repair proceeded exactly as predicted. Mrs. Patterson's cardiac function improved dramatically. Her tissue responded well to surgical intervention, and all complications were avoided through techniques that seemed to anticipate problems before they developed. Outstanding surgical work, Dr. Chen commented as we concluded the procedure. Your technical approach was flawless, but I felt as though I had been following instructions rather than making independent surgical decisions. The breathing in my mask had guided the entire procedure. Using my hands to perform techniques while my voice provided commentary I hadn't consciously formulated. When I removed the surgical mask in the post-operative area, the fabric was warm to the touch despite having been worn in the air-conditioned operating room. Not just warm from my body heat, but warm as if it had been shared with someone whose body temperature was higher than normal room conditions. I examined the mask carefully. Standard disposable material, no unusual features or modifications, but the interior surface showed two distinct wear patterns, one from my nose and mouth, and another set of impressions that suggested a second person had been sharing the mask. Mrs. Patterson's recovery was exceptional. Her cardiac function returned to normal parameters within hours of surgery, and she showed no complications from the valve repair procedure. Best outcome I've seen for this type of surgery, Dr. Chen reported. Whoever guided that procedure knew exactly what they were doing. I began paying attention to the breathing sounds and surgical masks during subsequent procedures. Not every mask produced the phenomenon, but occasionally I would detect the additional respiratory patterns that indicated shared occupancy, always during complex procedures that required exceptional surgical expertise. Always with accurate predictions and superior outcomes. Always with the breathing patterns that reminded me of Dr. Morrison's distinctive approach to cardiac surgery. Some surgical guidance, I've learned, comes from mentors whose expertise transcends their physical presence in operating rooms. And some masks contain more than sterile barriers. They hold the accumulated knowledge of surgeons whose dedication to patient care continues long after their own breathing has stopped. The whispered breathing in surgical masks represents the continuation of surgical mentorship that ensures complex procedures receive the guidance of experienced professionals whose expertise remains available when patients need the best possible care. Medical record keeping requires precise patient identification to ensure accurate treatment and prevent dangerous errors in care. Throughout my 22-year surgical career at Metropolitan General Hospital, I had maintained meticulous documentation, systems, and understood the critical importance of proper patient identification protocols, which is why discovering a filing cabinet full of admission forms that listed patients by number rather than name created such a disturbing breach of medical record standards. I found the files while cleaning out storage areas in preparation for the hospital's transition to fully electronic medical records. The old filing cabinet contained admission documentation dating back 15 years. But the forms were unlike any medical records I had seen before. Instead of patient names, each form listed only numbers: patient 1, patient 2, patient 3, continuing through patient 47. But the medical information was detailed and professionally documented: age, gender, medical history, presenting symptoms, and treatment plans. Strange filing system, I muttered, assuming the numbered forms represented some obsolete administrative experiment that had been abandoned in favor of standard patient identification methods. But as I reviewed the numbered forms more carefully, I began to recognize the medical cases they described. Patient 23, male, 67 years old, presenting with acute cholecystitis. Laparoscopic cholecystectomy recommended. Expected complications: minor bleeding, adhesions requiring conversion to open procedure. The case details matched exactly a surgery I had performed 3 weeks earlier on Mr. Robert Chen. Same age, same condition, same surgical approach, same complications that had required converting the laparoscopic procedure to traditional open surgery. But Mr. Chen's operation had occurred years after these forms were supposedly filed. I checked additional numbered forms, finding more matches with my recent surgical cases. Patient 31, female, 52 years old, presenting with appendicitis, appendectomy with complications from perforated appendix, extended recovery required. This matched Mrs. Sarah Martinez's case from last month. Same age, same condition, same complications from the perforated appendix that had made her surgery more complex than anticipated. Patient 19, male, 34 years old, presenting with gallbladder stones, routine cholecystectomy, no complications expected. Mr. James Wilson's case from 2 weeks earlier. Straightforward surgery that had proceeded exactly as predicted in the numbered form. Every numbered patient form corresponded to a surgical case I had performed recently. But the forms were dated years before those surgeries had occurred. I consulted the filing system more systematically, comparing the numbered forms to my surgical log from the past 6 months. The correlation was perfect. Every operation I had performed was represented by a numbered form that predicted the case details with impossible accuracy, but the forms were apparently filed before the patients had been admitted to the hospital. Dr. Peterson, our medical records administrator, was puzzled when I showed him the numbered forms. This isn't consistent with any filing system we've used. Patient identification by number violates multiple privacy regulations. But the case details are completely accurate, I explained, showing him the correlation between the numbered forms and my recent surgical cases. Dr. Peterson examined the documentation carefully. These forms predict surgical outcomes that hadn't occurred when they were supposedly filed. That's not possible, but the evidence was compelling. The numbered patient forms provided advanced documentation of surgical cases that would be performed years later, including complications and outcomes that proved accurate down to specific details. I continued reviewing the numbered forms, looking for patterns or explanations for their predictive accuracy. Patient 44, female, 73 years old, presenting with bowel obstruction, emergency surgery required. Complications from adhesions, extended operative time. Mrs. Dorothy Walsh's case from yesterday. The surgery had taken 6 hours due to extensive adhesions that made bowel repair more complex than anticipated, exactly as predicted in the numbered form dated 3 years earlier. Patient 45, male, 41 years old, presenting with acute pancreatitis. Non-surgical management initially, deterioration requiring pancreaticoduodenectomy. Mr. Kevin Martinez's case that was scheduled for next week. He was currently being treated medically for pancreatitis, but the numbered form predicted that his condition would worsen and require the complex pancreatic surgery that we hadn't yet discussed with him. The numbered forms were documenting not just past cases that matched my surgical experience, but future cases that hadn't yet occurred. At the bottom of the filing cabinet, I found one final form that made me pause. Patient 0, male, 58 years old, presenting with acute myocardial infarction during surgical procedure. Emergency cardiac intervention required. Prognosis uncertain. The age matched mine exactly. The form was dated for tomorrow's schedule, but I felt fine. No cardiac symptoms, no chest pain, no indication of heart problems. My most recent physical examination had shown normal cardiovascular function, yet the numbered form predicted that I would suffer a heart attack during tomorrow's surgical procedure and require emergency cardiac intervention. I consulted with Dr. Williams, our cardiology chief, about the prediction. He performed an immediate cardiac evaluation, including EKG, stress testing, and echocardiogram. Your cardiac function is excellent, he reported. No indication of coronary artery disease or risk factors for heart attack. But the numbered form was specific about timing and circumstances. Myocardial infarction during surgical procedure, requiring emergency intervention. The next day, I was scheduled to perform a routine gallbladder removal on Mrs. Betty Thompson. Standard laparoscopic procedure, low complexity, minimal risk factors, but at 10:47 a.m., during the initial laparoscopic exploration, I experienced severe chest pain and shortness of breath. Dr. Martinez is having chest pain, announced the anesthesiologist as my symptoms became apparent to the surgical team. Dr. Williams arrived within minutes, confirming that I was experiencing a heart attack. Emergency cardiac intervention was initiated while Mrs. Thompson remained under anesthesia with the surgical procedure suspended. The cardiac catheterization revealed a coronary artery blockage that required immediate stent placement. The intervention was successful, restoring normal blood flow and preventing permanent heart damage. Mrs. Thompson's surgery was completed by Dr. Chen while I recovered in the cardiac care unit. When I returned to work 2 weeks later, I found that the numbered patient forms had been updated with a new entry. Patient 48, female, 63 years old, presenting with gallbladder stones. Routine cholecystectomy completed by alternate surgeon due to attending physician medical emergency. No complications. Mrs. Thompson's case, documented in the same predictive format as all the other numbered forms. I've come to understand that some medical documentation exists outside normal temporal constraints, recording cases before they occur and predicting outcomes with accuracy that serves both patient care and physician preparation. The numbered patient forms represent a filing system that transcends conventional record keeping, ensuring that surgical cases receive appropriate attention and that complications are anticipated before they develop. Patient, whose prediction of my heart attack allowed for immediate recognition and treatment that prevented a potentially fatal outcome, demonstrating that some documentation serves protective purposes that exist beyond standard medical record requirements. Surgical procedures follow predictable timelines based on complexity, patient condition, and technical requirements. During my 3rd year of surgical residency at General Hospital, I had assisted in hundreds of operations and developed reliable expectations for procedure. Duration and postoperative protocols. A routine appendectomy typically required 60 to 90 minutes from incision to closure. Complex cardiac procedures might extend to 6 hours. Even the most complicated surgical cases rarely exceeded 8 hours of continuous operative time. But the appendectomy I assisted with on Tuesday, October 15th, seemed to continue for 3 days without reaching completion. The case began normally. Mrs. Catherine Morrison, 43 years old, presented with classic appendicitis symptoms and was scheduled for laparoscopic appendectomy under Dr. Patterson's supervision. Straightforward procedure, minimal risk factors, expected duration of 1 hour. I joined the surgical team at 2:30 p.m., assisting with routine tasks while Dr. Patterson performed the laparoscopic exploration to locate and remove the inflamed appendix. Appendix is moderately inflamed but contained, Dr. Patterson reported. Standard removal procedure. The initial laparoscopic approach proceeded normally. Trocar placement, insufflation, camera insertion, identification of anatomical structures, everything consistent with routine appendectomy protocols. But when Dr. Patterson began to dissect the appendix from surrounding tissue, something unusual occurred. The appendix appeared to regenerate tissue as fast as we removed it. "That's strange," Dr. Patterson muttered, cauterizing blood vessels that seemed to reform immediately after being sealed. I observed the surgical site through the laparoscopic monitor. The appendix showed the expected inflammation, but each attempt to separate it from the cecum resulted in new tissue connections that hadn't been present moments earlier. "Are we looking at the same appendix?" I asked. Dr. Patterson attempted to grasp the appendix with laparoscopic forceps, but the tissue slipped away, becoming somehow larger and more complicated than standard appendiceal anatomy would suggest. "Let's convert to open procedure," he decided. "Better visualization and control." The conversion from laparoscopic to open surgery required additional incisions and surgical exposure. But when we opened Mrs. Morrison's abdomen, the appendix had become a complex mass of tissue that extended far beyond normal anatomical boundaries. "This doesn't look like appendicitis," Dr. Patterson observed. "More like, well, I'm not sure what it looks like. The tissue mass required careful dissection to avoid damage to surrounding organs. Each layer we removed revealed additional complexity underneath, as if the surgical site were generating new anatomical challenges to replace the ones we had addressed. After 4 hours of careful dissection, we had made minimal progress toward completing the appendectomy. The tissue mass had actually increased in size and complexity despite our surgical efforts. "How long have we been operating?" I asked. Dr. Patterson checked the wall clock. 4 hours, 20 minutes, but it feels like much longer. The anesthesiologist confirmed the time duration. "Patient has been under anesthesia for 4.5 hours. Vital signs remain stable, but my subjective experience suggested we had been working much longer. The fatigue in my legs felt like standing for 12 hours. The strain in my neck and shoulders suggested extended surgical positioning. Let's take a brief break," Dr. Patterson decided, "reassess our approach." But when we attempted to step away from the surgical table, we discovered something impossible. We couldn't leave, not physically restrained, but unable to move more than a few steps from the surgical site. An invisible barrier seemed to prevent us from exiting the operating room or even stepping away from Mrs. Morrison's open abdomen. "I can't seem to leave the surgical field," I reported. Dr. Patterson attempted to walk toward the door. He moved normally until reaching the edge of the sterile area, then stopped as if encountering a solid wall. "Something's preventing us from leaving," he confirmed. The scrub nurse and anesthesiologist reported similar limitations. They could move within their normal work areas but couldn't exit the operating room or step outside their assigned positions. We were confined to the surgical space until the procedure could be completed, but the procedure refused to reach completion. Each attempt to remove the appendiceal tissue resulted in more complex anatomy that required additional dissection. Every suture we placed would dissolve, requiring resuturing. Every blood vessel we cauterized would reopen, requiring additional hemostasis. The surgical site had become a self-renewing challenge that generated new problems as fast as we solved the existing ones. "Patient is stable," the anesthesiologist reported periodically. "But I'm concerned about the duration of anesthesia." Mrs. Morrison's vital signs remained excellent throughout the extended procedure. Her body showed no signs of stress from the prolonged surgical time, or the inability to complete the operation. But we continued working, unable to leave, unable to finish, trapped in a surgical procedure that defied completion. My watch indicated 12 hours of operative time, but my experience suggested we had been working for days. The lighting in the operating room never changed. The clocks showed varying times that didn't correspond to each other, and the outside windows remained dark, regardless of what time the various timepieces displayed. "Are we still on Tuesday?" I asked during one of our brief rest periods. "I think so," Dr. Patterson replied, but his uncertainty was obvious. The surgical procedure continued through what felt like multiple days and nights. We would work for hours, make progress toward completing the appendectomy, then discover that our work had somehow undone itself and we needed to begin again. Sutures would disappear. Incisions would reopen. Tissue we had removed would regenerate in more complex configurations that required different surgical approaches. But Mrs. Morrison remained stable throughout the impossible procedure, showing no signs of surgical trauma or anesthetic complications despite the extended operative time. Patient condition excellent, the anesthesiologist reported at regular intervals. All parameters normal. On what felt like the third day of continuous surgery, we finally achieved something resembling completion. The appendiceal tissue was removed, the surgical site was clean, and closure could begin. But as we prepared to suture the abdominal incisions, we discovered that Mrs. Morrison's abdomen had healed itself. No incisions were visible. Her skin was intact, showing no signs of surgical entry. The laparoscopic port sites had disappeared, and her abdomen appeared exactly as it would have before any surgical intervention. "Where are the incisions?" I asked. Dr. Patterson examined Mrs. Morrison's abdomen carefully. Perfect skin integrity, no surgical trauma, no indication that any procedure had been performed. But we had clear memories of 3 days of continuous surgery. The operating room doors opened suddenly, releasing us from the invisible containment that had prevented our departure. "How did the appendectomy go?" asked the recovery room nurse, arriving to transport Mrs. Morrison. I checked the surgical clock. 9:30 p.m. According to the time display, we had been operating for 7 hours, longer than expected for appendectomy, but within reasonable parameters for a complicated case. But our subjective experience suggested 3 days of continuous surgical work. Mrs. Morrison recovered quickly from anesthesia, showing no signs of surgical trauma or extended operative stress. Her vital signs were excellent, her pain was minimal, and her abdomen showed no evidence of surgical intervention. Did we actually perform surgery? I asked Dr. Patterson privately. He reviewed his surgical notes, which documented a standard appendectomy with minor complications requiring extended operative time. According to my documentation, we removed her appendix successfully. But Mrs. Morrison's medical record contained no operative report, no anesthesia record, and no nursing documentation of surgical procedure. Her chart was blank, as if no surgery had been performed. She was discharged the following morning with no complications and no evidence of appendectomy, but Dr. Patterson and I retained vivid memories of 3 days of impossible surgery that had simultaneously occurred and not occurred, leaving us with the exhaustion of extended operative work and the confusion of a procedure that had no documented outcome. Some surgeries, I've learned, exist in temporal spaces that don't correspond to normal operative schedules, requiring dedication that transcends conventional limits of time and endurance, while serving purposes that exist beyond standard surgical documentation. Post-operative recovery requires careful monitoring of patients emerging from anesthesia. Vital signs, pain management, consciousness levels, and emotional support must be continuously assessed to ensure safe transition from surgical procedures to normal awareness. During my 9 years as recovery room nurse at Metropolitan Hospital, I had cared for thousands of patients during this critical period and understood the importance of responsive attention to post-surgical needs, but the sobbing that began emanating from empty recovery bays challenged my understanding of who required comfort during the vulnerable hours following surgery. The crying started subtly during quiet evening shifts when most surgical procedures had concluded and only a few patients occupied the recovery area. Soft sobbing from behind the curtained partition of Bay 7, which was supposed to be empty and prepared for the next admission. Someone's crying in Bay 7, I reported to Linda, the charge nurse. She checked her assignment board. Bay 7 is vacant. Has been since Mr. Thompson was discharged this afternoon. But the sobbing continued. Gentle, heartbroken weeping that suggested someone in significant emotional distress. I walked to Bay 7 and pulled back the curtain. Empty bed, clean linens, no patient present. But the sound of crying continued, seeming to come from the unoccupied space where a patient should have been lying. Hello? I called softly. Is someone here? The sobbing paused briefly, then resumed with increased intensity, as if my acknowledgement had provided permission for more open expression of distress. But no one was visible in the bay. I checked the adjacent recovery areas, thinking the sound might be carrying from another patient who needed attention. All occupied bays contained patients who were resting quietly or recovering normally from their procedures. The crying originated specifically from the empty Bay 7. Over the following weeks, the pattern expanded to other empty recovery bays. Soft sobbing from Bay 3, gentle weeping from Bay 12, quiet crying from Bay 15, always from spaces that contained no patients, but somehow housed sources of emotional distress. Do you hear crying from the empty bays? I asked other recovery room staff. All the time, replied Sarah, one of our senior nurses. It's been happening for months. We've learned to check on the empty spaces as much as the occupied ones, but checking on empty bays revealed no patients requiring comfort or medical attention. The yet invisible crying patients seemed to respond to normal nursing interventions. When I spoke soothingly to the empty bays, the sobbing would quiet. When I explained what was happening in the recovery room, the weeping would pause as if listening attentively. You're safe now, I would tell the empty spaces. Surgery is complete. Everything went well. The crying would diminish, suggesting that reassurance was being received and appreciated by the unseen patients. But the most disturbing aspect was the correlation between the invisible crying and surgical procedures occurring elsewhere in the hospital. During complex operations in the main surgical suites, the sobbing from empty recovery bays would intensify. When patients in operating theater 3 were placed under anesthesia, the crying from Bay 7 would become more urgent and distressed. The empty bays seemed to respond to what's happening in surgery, I observed to Dr. Martinez, our recovery room physician. Respond how? When patients go under anesthesia upstairs, the crying down here gets louder. Like they're connected somehow. Dr. Martinez was skeptical but agreed to monitor the correlation. During a cardiac surgery that required deep anesthesia and heart-lung bypass, the crying from multiple empty recovery bays became almost overwhelming. It's like they're experiencing the surgery, I reported, crying because they're scared or in pain. But the patients actually undergoing surgery were unconscious and comfortable, showing no signs of distress or awareness. The invisible patients in recovery seemed to be experiencing the emotional trauma that the anesthetized patients couldn't feel during their procedures. I began providing more systematic comfort to the empty bays during surgical cases, speaking reassuringly, explaining procedures, offering emotional support to the unseen patients who seemed to be carrying the fear and anxiety that anesthesia prevented the visible patients from experiencing. The surgery is going very well, I would tell the empty spaces. The doctors are taking excellent care. You'll feel much better soon. The crying would calm, suggesting that information and reassurance were effective for the invisible patients who seemed to be emotionally connected to the surgical procedures. Dr. Peterson, our anesthesiologist, was intrigued by the correlation between anesthesia depth and recovery room crying. It's as if consciousness is being displaced rather than eliminated. The awareness has to go somewhere when we suppress it during surgery. Could the empty recovery bays be holding displaced consciousness? That's not scientifically possible, but your observations are consistent with some form of consciousness transfer. We began documenting the relationship between surgical anesthesia and invisible patient distress in recovery. The pattern was consistent. Deeper anesthesia in surgery corresponded to more intense crying from empty recovery bays. The invisible patients appeared to be experiencing the surgical procedures that the anesthetized patients couldn't consciously perceive. I started requesting that surgical teams provide updates about procedure progress so I could relay information to the crying patients in empty recovery bays. The surgery is half complete. I would announce to the vacant spaces, everything is proceeding normally. The patient is stable and comfortable. The sobbing would quiet. as if the invisible patients were reassured by progress reports about procedures. They seemed to be experiencing second-hand patient. Charts began listing the empty recovery bays as occupied by not admitted patients who required emotional support and comfort care during surgical procedures. Bay, but not admitted patient, requires reassurance during cardiac surgery. Responded well to verbal comfort. Crying diminished with progress. Updates. The documentation created official recognition of the invisible patients who seemed to be carrying the emotional burden of surgical procedures for the anesthetized patients who couldn't experience fear or distress during their operations. Some consciousness, I've learned, doesn't simply disappear during anesthesia, but relocates to spaces where it can experience the procedures without interfering with surgical success. The crying from empty recovery bays represents displaced awareness that ensures patients' emotional needs are acknowledged and addressed even when anesthesia prevents their direct expression of fear or anxiety. The invisible patients in recovery provide a service by experiencing the psychological aspects of surgery, allowing the physical patients to undergo procedures without conscious distress, while ensuring that someone receives the comfort and reassurance that surgical situations require. Surgical consent forms represent the most critical documentation in medical practice, ensuring that patients understand the risks and benefits of procedures and providing legal authorization for surgical intervention. During my 14 years as patient services coordinator at Regional Medical Center, I had processed thousands of consent forms and understood the meticulous attention required for proper surgical authorization. But the consent form I discovered in the surgical scheduling office challenged everything I knew about patient consent and surgical documentation. I found it while organizing paperwork for the next day's surgical schedule, filed among the standard preoperative documents that patients had signed during their admission process. The form appeared normal at first glance: standard hospital consent format, proper medical terminology, appropriate legal language. But the signature was written in what appeared to be fresh blood. Not the blue or black ink typically used for medical documentation, but dark red fluid that looked wet despite being applied to paper that should have absorbed liquid immediately. I examined the form more carefully. The patient's name was listed as final patient, which wasn't a real name in our hospital system. The procedure was described as termination of medical practice, which wasn't a recognized surgical intervention, but the form was properly formatted and professionally completed, with all required information filled in according to hospital consent protocols. The signature at the bottom of the form was disturbing for multiple reasons. First, it was clearly written in blood rather than ink. Second, the handwriting looked familiar, similar to surgical consent signatures I had seen many times before. It resembled Dr. Morrison's signature, our chief of surgery. I consulted our patient database to verify information about final patient. No one by that name was scheduled for surgery. No one with that designation was admitted to the hospital, and no medical records existed for anyone matching that identification. But the consent form was dated for tomorrow's surgical schedule and filed with legitimate preoperative documentation. I brought the unusual form to Dr. Morrison's attention during the afternoon surgical planning meeting. Dr. Morrison, could you verify this consent form? The signature looks like yours, but I can't find the corresponding patient. He examined the blood-signed document carefully. I didn't sign this. I've never seen a consent form for termination of medical practice. That's not a real surgical procedure, but the handwriting was unmistakably similar to Dr. Morrison's documented signature on hundreds of legitimate consent forms. The signature matches your handwriting style, I observed. Dr. Morrison compared the blood signature to his normal documentation. It does look like my writing, but I definitely didn't sign this form. We consulted with hospital administration about the mysterious consent form. The legal department was concerned about unauthorized documentation that might create liability issues. Consent forms signed in blood aren't legally valid, the hospital attorney explained. But this raises questions about document security and patient identification protocols. But the form continued to trouble me because of its professional completion and accurate formatting. Someone with detailed knowledge of surgical consent procedures had created documentation that followed hospital protocols. Precisely. I researched the procedure described as termination of medical practice to determine if it might represent some legitimate surgical intervention using unusual terminology, but no medical literature described any procedure by that name, and no surgical codes existed for interventions that would match that description. The consent form appeared to authorize a procedure that didn't exist in medical practice. Over the following days, I monitored the surgical schedule to see if final patient would appear on operating room assignments or if anyone would claim the mysterious consent form. But no patient materialized, and no surgical team reported receiving authorization for termination of medical practice. The blood-signed consent form remained an isolated anomaly in our documentation system. A week later, I discovered additional consent forms with similar characteristics. Different patient names, last patient, concluding patient, ultimate patient, but all signed in blood. All authorizing the same impossible procedure, all bearing signatures that resembled the handwriting of various surgical staff members. Dr. Peterson's apparent signature on a consent form for last patient. Dr. Williams' seeming signature, authorizing surgery for concluding patient. Dr. Martinez's suspected signature on documentation for ultimate patient, but none of the surgeons acknowledged signing the blood-written forms or having any knowledge of the patients listed. Someone is forging our signatures using blood instead of ink, Dr. Peterson concluded, but I can't imagine why anyone would create false surgical consent forms. The pattern continued over several weeks. Blood-signed consent forms for non-existent patients, authorizing impossible procedures, bearing signatures that matched our surgical staff's handwriting but weren't acknowledged by the physicians whose names appeared on the documents, all dated for future surgical schedules that never included the authorized procedures. But the most disturbing development occurred when I found a consent form signed with my own apparent signature, patient. Services coordinator was listed as the patient name. Termination of documentation review was described as the procedure. My signature, written in blood, authorized the intervention, but I had no memory of signing the form, and I certainly hadn't authorized surgery on myself. The blood signature matched my handwriting exactly, including the distinctive flourishes and letter formations that characterized my personal documentation style. But I would have remembered signing a consent form in blood, and I definitely wouldn't have authorized surgery to terminate my own job responsibilities. I consulted with Dr. Morrison about the implications of finding my apparent signature on a blood-signed consent form. This suggests that someone has access to samples of all our handwriting, he observed. But the blood signatures are too accurate to be simple forgeries. Could someone be using our blood to create authentic signatures? Dr. Morrison considered the disturbing possibility. That would require access to blood samples from multiple staff members and knowledge of each person's signature characteristics. But the alternative explanations were even more troubling. The signatures were too accurate to be forgeries, too consistent to be coincidental, and too numerous to represent isolated incidents. Someone or something was creating consent forms that documented authorization for procedures that existed outside normal medical practice, using signatures that appeared to be authentic but weren't acknowledged by the people whose names appeared on the forms. The blood-signed consent forms accumulated in my files, creating a collection of impossible documentation that authorized surgical interventions for patients who didn't exist using signatures from staff members who denied writing them. But the most unsettling aspect was the temporal pattern. Each consent form was dated for future surgical schedules, suggesting that the blood signatures were authorizing procedures that hadn't yet been performed, as if the forms were preparing for surgical interventions that would eventually be required, even though the procedures weren't currently recognized as legitimate medical practices. Some consent forms, I've learned, authorize procedures that exist outside current medical knowledge, ensuring that future surgical interventions will have proper documentation when the techniques become necessary. The blood signatures may represent advance authorization from surgical staff whose expertise will be required for procedures that don't yet exist in standard medical practice, creating consent documentation that bridges the gap between current surgical capabilities and future medical needs. The forms remain filed in my office, signed in blood that never dries, authorizing procedures for patients who may not yet exist but will eventually require surgical intervention that transcends the boundaries of conventional medical practice.